And then share screen is also on the bottom panel.
I think I'm sharing the screen. Are you guys able to see it? No.
I can see this.
Okay, perfect. I think we are around 22 people now. It's about 3:05. Is it a good time to get started? I think.
Take it away.
Yeah, let's do it. All right. Just want to, I think everybody can see my screen, right? Just want somebody to say yes to that, if that's the case.
Yes, we can.
Okay, perfect. Thank you. All right, awesome. So people who don't know me, I'm Abraham Sonny. I'm at MGH. I work in the departments of cardiac anesthesia and critical care. This lecture will basically focus on ICU management and mostly, and mostly for we'll try to cover it in about like 30 to 35 minutes, focusing on mostly on ICU management of COVID. All right, perfect. So the outline of the talk would be, we'll talk about the epidemiology of ICU disease. We'll talk about evidence-based ARDS management, which is really the cornerstone of what we'll be doing for these patients. We'll also talk about some other supportive therapy in the ICU. We'll also talk about some focused therapies for COVID because that keeps coming up in various discussions and in the news and in other places. And we'll also briefly touch upon, we'll consolidate everything with the MGH guidelines. So to begin with, the burden of ICU disease. So there are a couple of publications out there which talks about like how many patients gets admitted to the ICU and what level of organ dysfunction and care they need in the ICU. So this data is from China, Wuhan. It seems like around 70 to 80% of the patients are ambulatory, and only about 20% get admitted to the hospital, of which around 5 to maybe 8% need ICU care or invasive ventilation. This again supports the same thing, the data from Italy. So again, around 5% are critically ill or needing invasive ventilation, and seems like around 70% are ambulatory in the community. They also have a table which shows the case fatality rate, patients according to age. As you can see, it sharply goes up in older individuals. So it's more than 10% in patients more than 70 years of age, and more, approaching 20% in patients more than 80 years of age. So that is that has been reported by many other groups too. Before I start on the ICU management, I just wanted to put this slide here. Part of the reason is because there has been many articles on COVID-19 which talks about different stages of how the disease evolves. I also want to point out that it is tough. It is rare to see these stages, and a lot of times it is just these stages overlap a lot, and some patients don't just go through one stage and don't reach stage 3. So a small percentage of patients that we see in the ICU are patients who probably had some sort of baseline illness which is non-severe but symptomatic, which has been going on for a few days, and then they progress to a more severe dysregulated inflammatory response, as you would see with sepsis or other inflammatory diseases, where the body's reaction, it seems like the body's reaction to the pathogen produces a dysregulative response, leading to what we see. A lot of what we see in these patients is a hyperinflammatory response, which might be contributing to the ARDS. Also, the primary pathogen also is contributing to the destruction of the lung. So before we go on to talk more about ARDS, just to talk about the pattern of organ damage that we see in these patients. There are 2 studies which came out, all obviously single-centered and retrospective, looking at what sort of organ dysfunction they were seeing in the ICU. So this study came out in the Lancet and came out of China, Wuhan. and they have about 52 patients. The mean age is 60 in their ICU cohort, so 52 patients in the ICU, and about three-quarters, about two-thirds of them had ARDS. As you can see, other organ injuries, not as much. The AKI was around 30%. Cardiac injury is reported 23%, and it is kind of varied between different reports, and it has to be looked at with a little bit of skepticism, because how cardiac injury is defined is by elevation of troponin. We see an elevation of troponin in many critically ill patients, but also which could be related to demand and might not be primarily a stress-induced cardiomyopathy. None of these patients were proven or shown to have LV dysfunction with an echo, but most of these diagnoses were reported based on troponin elevations. About half of the patients required invasive mechanical ventilation, and about surprisingly, only one-third of the patients, one-third of the group, needed vasoconstrictive agents, which is also an interesting finding. And this slide is on the Seattle cohort, which is where we saw our initial outbreak. And it's about 24 patients from the Seattle cohort, which is published in NEJM, and their mean age was 64. Sort of comparing this with the previous slide, you can see that the vasopressor requirement was seen in about 71% of the patients here, while and a higher percentage of the patients here required invasive mechanical ventilation. Part of it has been attributed to the fact that the outbreak in Seattle started in a SNF and spread initially in the nursing home. So probably we are looking at just a baseline sicker population. Again, here we see that they performed echo in about like 40% of their patients did not see LV dysfunction in any of the echoes that they performed. And so based on, just to summarize what we talked about in the last couple of slides, about 80% of the patients are ambulatory, 5 to 10% need ICU care, and majority of the patients have a single system involvement, which is ARDS. So that is majority of what we see. There are some patients, there are definitely a certain group of patients who develop like renal dysfunction, cardiac dysfunction, and others, but and also some distributive shock. But majority of what we see is ARDS. A word of caution as we move further into the presentation is we should keep in mind that there has been decades of research in ARDS, and we know how to manage ARDS, and there's a lot of evidence-based strategies to do that. Also, in the last few months, we see a lot of anecdotal case series, retrospective data coming out in really great journals like NEJM and JAMA, and rightly so, because we know so little about like the SARS coronavirus 2 that we want to see any information which comes out. But we should be also very cautious in weighing that information against randomized controlled trials or other age-old or proven practices or mortality benefiting practices in the ARDS that we have been following. We should be cautious not to outweigh some of the recommendations these case reports or case studies might say, which might go against this. So we have to sort of keep that in mind as we glance through literature as we know more about this disease. A quick, I want to give a 2 to 3 minute review on ARDS. So what you're seeing on the left side is a cross-section, a cross-section of the lung. In the CT scan, we see the left and the right lung here, and the heterogeneous nature of the insult. Basically, you're seeing there's a pacification, there's loss of surfactant leading to alveoli, which are unstable and they collapse. And that is what leads to basically ARDS. And so we see these collapsed alveoli, collapsed lung units, more so in this region, in the posterior region, some here, and then the anterior portion of what we see here, at least in this image, is relatively normal lungs. And this heterogeneous picture of some portion of the lungs with severe injury and some portion of the lungs which act like normal lung is really the hallmark of ARDS. The Berlin definition to classify a patient to have ARDS is basically somebody who has symptoms, respiratory symptoms for about a week, and then presents to us with bilateral lung opacities on an X-ray or CT, which is not explained by cardiogenic causes. And the patient has a PF ratio of less than 3% despite having a PEEP of more than 5. So in this picture, what I've done is I've tried to divide lungs as the lung fields here based on which is more affected versus not by the disease process. So here you can see the anterior portion of the lung, which is B, which is sort of here, is less affected and it's more normal. And the posterior portion, which is depicted by A here, is the more consolidated portion, the portion with more airspace disease, and which is a heterogeneous part of the lung which is more affected by ARDS. The challenge is that when both these require different types of ventilatory strategies. However, there's only one way we can ventilate these lungs, ventilate the whole lung. We cannot individually ventilate portions of the lung because you can only apply pressure on the endotracheal tube or PEEP at the endotracheal tube. So this dotted line here represents the normal lung. This is a pressure volume curve. So we have plotted transpulmonary pressure on this axis and volume on this axis here. And then this is the pressure volume curve of a normal lung. And what you're seeing below here in the solid line is the pressure volume curve of a diseased lung. So this is A, and this what you're seeing here is B here. So while we focus on the ARDS lung here, the solid line, which is the lung depicted by A, we ideally want to keep all the alveoli open throughout the ventilatory cycle, which means that we want to PEEP, which will keep keep most of the alveoli open even at the end of expiration. So we want to PEEP more than the lower inflection point. And we also don't want the tidal volumes higher than the upper inflection point, meaning that giving more tidal volume or volume here does not expand the stiff lungs more, but just increases the pressure and cause injury. So it just increases the pressure, but does not actually increase the volume. And so you want to basically ventilate the lungs in this region. The problem is that in the normal lung, that the mechanics is completely different, or this portion of the lung which is normal or less affected has a completely different mechanics, and they lie on a different portion of the curve. And if you're ventilating the whole lung with something which is only relevant for the ARDS lung, we are gonna cause injury and hyperinflation and damage to the normal lung. And that is sort of the challenge of the ARDS, and that is a lot of what most of the studies have tried to address while trying to decrease mortality. So again, it's the same diagram here. We're trying to find the safe window of ventilation where we are keeping the ARDS or diseased lung open and not over distending them with tidal volume. At the same time, we are not over distending the baby lungs, or so to speak, the normal non-diseased lungs we see in these patients interspersed between the diseased lung. I've put together like main strategies that have shown to be beneficial in ARDS. So really the cornerstone for treatment is low tidal volume ventilation. That is something which has been proven on multiple studies and has a pretty good effect size in terms of how that would are repeatedly shown in different studies. The other strategies are how to optimize mechanics, that is by using PEEP and prone positioning. And then we have a conservative fluid management strategy, which should also help with the ARDS. So the most quoted study of low tidal volume ventilation, which we all know about, is a New England Journal study from 2000, which divided patients into traditional tidal volume and low tidal volume group. And the ARMA study, which the traditional tidal volume group received 12 cc per kilo, which is quite unheard of at this point. And we have the low tidal volume group, which they started off as 6 cc per kilo, and they could go down up to 4 cc to accommodate a maximum plateau pressure of 30. The important thing I wanted to highlight here is it is 6 cc per kilo of predicted body weight, which means that it is body weight predicted based on a table for patients based on their height. So it is not the actual body weight of the patient. This is cc per kilo of the body weight predicted based on that patient's height. They used assist control volume control ventilation, kept the plateaus less than 30, and they used a arbitrary PEEP FiO2 table to decide what PEEP to use, and they allowed permissive hypercapnia so that a low tidal volume ventilation can be achieved. This is their results. So they have this the top two lines are the mortality, the survival lines. So patients who, the solid line is for the patients who received low tidal volume, and this line, dotted line here, is patients who received traditional tidal volume, and you can see a significant effect size in their survival. It's actually 30% versus 40%, so almost 25% decrease in mortality, which is pretty remarkable. And as I move to driving pressure, talking about driving pressure, I just want to harp upon this point that what they've used at that point is something. What they used in that study is something we continue to use for standard ARDS management. It is probably the most effective thing. And so to keeping tidal volumes in these patients less than 6 cc per kilo of their predicted body weight, using assist control ventilation, keeping the plateaus low, and allowing for permissive hypercapnia. This is a time-tested strategy for reducing mortality in ARDS. Another aspect which has come up in the recent times is driving pressure. The intervention group in ARDS study that we saw before had they basically looked at lower tidal volumes and plateau pressures, and that was a strategy to decrease injury to the native lungs, or injury to the non-diseased lung. Is there a better ventilator parameter which predicts mortality in ARDS? So this question has been raised, and people have looked at driving pressure as a combined parameter, or a parameter which might be a better predictor of mortality. Driving pressure is basically difference between your plateau pressure and your PEEP. So if this is your pressure time graph on your ventilator, when you deliver a breath, this is your peak inspiratory pressure. And then if you do an inspiratory hold, usually for about a second or 0.5 seconds, you get your pressure sort of settles out to a plateau when the airway resistance is no more contributing to the pressure on the pressure time graph. And this difference between the PEEP plateau and the PEEP we are giving the patient is actually the driving pressure, or what we call the delta P. That's an important component in determining the compliance of the patient. So compliance is tidal volume divided by the driving pressure. And so driving pressure has been looked at in a couple of studies, with the most importantly by Marcelo Amado, who published in the NEJM 2015. He pulled together various ARDS studies and pulled the patients together, looked at their PEEP, their driving pressures, and their plateau pressures in these patients, and then tried to correlate that with mortality. I want to draw your attention to the two graphs in the center. The two graphs, one on top of each other. The one on the top, you can see here, the dark portions of this histogram, or the black portions of the histogram, basically is the PEEP. The gray portion is the driving pressure. And the graphs on the bottom are showing mortality. These are relative risk of mortality in these patient groups. So he divided patients into 5 groups here, and with increasing plateau pressures. So one would expect that as the plateau pressures of patients go up, their mortality should also go up, because that would mean, their lungs are less compliant, and the probably patients will do worse with higher plateau pressures. However, if the groups are chosen such that although the plateau pressure increases, their driving pressure remains the same, actually their mortality doesn't change. Their mortality is exactly the same if their driving pressure is the same. On the same hand, if you look at the graph onto your right after that, you see this group of patients. Again, Marcelo Mato has divided patients, and his group has divided patients into 5 groups. Each group has the same plateau pressures. However, their driving pressures decrease. And as you can see, as the driving pressure decreases, your mortality decreases. Going back to the first graph again, the same thing. As he has kept the PEEP constant here, and your driving pressure goes up with each cohort, and you can see the mortality goes up. So it seems like the most important portion of what will help determine mortality from event setting standpoint is driving pressure. And again, that is shown by this graph from the same paper, which shows that about 15, driving pressure 15 is sort of the inflection point, where above that we have a relative risk of mortality of more than 1. So what we usually go by clinically is to try to limit your driving pressure to less than 15 when ventilating these patients. So clinically, it is an easy parameter to measure, and it's easy to follow clinically. It's actually reported in EPIC by the respiratory therapist, so you can easily look at it in the flowcharts. And any intervention, so I'm happy whenever I see that a patient's driving pressure is better by a certain intervention I did. For instance, if the patient's driving pressure is, say, 18, that would force me to reduce my tidal volumes to 4, or force me to maybe say I should paralyze this patient. And if those decreases the driving pressure, that would be something which should probably impact his or her mortality. So in addition to doing low tidal volume, I see this as a parameter I can look at when I'm adjusting other things. How to improve mechanics? We talked about, we mentioned prone positioning and PEEP titration, getting the optimal PEEP for these patients. So we'll initially talk about prone positioning, and we have this study, which is ProSEVA study, which came out in 2013, which basically looked at prone patients for about 16 hours a day when their PF ratios were less than 150, and they found a significant mortality benefit in these patients. This is the first study which actually showed a benefit for prone positioning, and since then there's been a lot of talks about a lot of interest in prone positioning, and that has led to various meta-analysis to see why previous studies were not that effective. And that brings me to the next 2 slides, which are meta-analysis looking at 8 randomized trials, including this one. And the reason is thought to be probably the previous studies are negative, probably because many of the earliest studies actually used non-lung protective ventilation strategies, because they were much earlier, like they were in the early 2000s. Even though they were after the low tidal volume study, people had not widely adopted low tidal volume ventilation yet. And when you stratify studies based on lung protective strategy versus non-lung protective strategy, actually you see an effect size for prone patients are the same. Another important aspect of that is this next slide on the same meta-analysis, is that when you stratify studies based on whether they're prone patients for more than 12 hours or less than 12 hours, there's a significant benefit to proning, a significant mortality benefit to proning if you prone them for more than 12 hours a day. And that is what we are doing with most of our patients who satisfy criteria for being prone. is to prone them for at least 16 hours a day, if not more. For there are a few patients we have prone for 24 hours or more too. The reason being that their mechanics, their lung mechanics is markedly better when they're prone, as has been shown in various studies and in animal models as well. The posterior portion of the lung is really difficult to ventilate because of how stiff the spine and the posterior part of the ribs are, and those are much better ventilated. They move to a much better portion of the pressure volume curve when the patients are prone, thereby actually decreases their driving pressures and improves their PF ratio, just overall improving the lung mechanics overall and decreasing injury. So that is something we have adopted widely in our COVID patients. How to set PEEP is the other aspect. We can choose the PEEP which gives us the highest compliance, or the lowest driving pressure, basically the same, or we can use titrated based on the ArtsNet PEEP FIOD table, which is actually shown here. So either of them are fine because there's no evidence supporting one strategy or the other. But as a group, we have followed the compliance a way of titrating PEEP because that makes more physiological sense. So most of our respiratory therapists and once would do a compliance-based best PEEP trial when the patients come to our unit, and then we would set the PEEP 2 centimeters of water above where the optimal PEEP is, and that would provide the best mechanics or the lowest driving pressure for these patients. So another thing I wanted to focus your attention on is the patient ventilator dysynchrony. So that is something we have to keep our eye on for these patients. So in addition to low tidal volume ventilation, we talked about minimizing our driving pressures. When dysynchrony will undo all of the good you did in terms of low tidal volume ventilation and all of the strategies that you have done. An example is, the most common example is actually double triggering that is shown in this chart, is that as soon as the patient exhales, starts to exhale, he takes a short breath and that triggers another ventilator breath because it's assist controlled ventilation. So in effect, even before the patient completely exhales the breath one here, he gets another breath. So he basically gets almost double the tidal volume, which would be around like 10 to 12 cc per kilo, right? And that would be injurious to his lung. And that is sort of the mechanism how ventilator dysynchrony, patient ventilator dysynchrony actually worsens outcomes. So this happens because low tidal volume ventilation is not really physiological for patients, and so patients fight it. It is tough. They have a high ventilatory drive because they're hypoxemic. So the only way to kind of circumvent that is to sedate patients really heavily. And that is, at least in the COVID patients, that's been a challenge. We have been sedating them with propofol and found that we need really high dose of propofol, almost general anesthetic doses. So we are using high dose narcotic drips. And when we have OR ventilators or anesthesia machines being used as ICU ventilators, in which we are doing in one of our units, we can actually resort to using isoflurane, which seems to work better in these patients. So heavy sedation, and even at times, even with sedation, these patients still have dysynchrony, and that is when we have to paralyze these patients. Avoiding dysynchrony is key and really important in decreasing lung injury, and that will be key in reducing mortality in these patients. So whatever it takes to prevent patient ventilator dysynchrony, either heavy sedation, if that doesn't work, then paralysis is what it would be the right strategy for these patients. I have a slide on role of paralysis because that do come up as a question, is should we paralyze all these patients? So systematic paralysis in ARDS for all patients have been tried in a randomized controlled trial and has been shown not to improve mortality. Our institution was part of this. This came out in the NEJM in 2019. So there's no role for systematic paralysis of all patients in ARDS. We should paralyze them when we see vent dysynchrony, which cannot be managed with sedation. When to intubate COVID patients. So different thresholds are across all over the world and the US. At MGH, what we have adopted is if they're requiring an they have an oxygen requirement of more than 5 to 6 liters per minute of nasal cannula, we are actively thinking about intubating this patient at that point. The rationale for this approach is two. One is it is to protect the healthcare provider. You don't want to be intubating these patients when they are failing on non-rebreather, on high flow, and in an urgent way. Because what you have seen is intubating these patients takes time, donning the PPE and getting everything set up. Since we have minimum number of providers in the room, you don't want to go in and out of the room multiple times. So it takes about like half an hour to 45 minutes to almost up to an hour the first time you intubate these patients. And so we want to do it in a controlled way. So we don't want to be too late in intubating these patients. The other important aspect is self-induced lung injury. There's a lot of literature which has come up recently, animal as well as human literature, which shows that having high minute ventilations, as these patients have in respiratory distress, without controlling their tidal volumes as you would in a mechanically ventilated breath, leads to high transpulmonary pressures, and which is basically the driving pressures that we're talking about. So high driving pressures, and that leads to lung injury even in spontaneously breathing patients. So there is a role. These are the two reasons why we would intubate these patients at a time. There are institutions in the US which are using high flow and BiPAP or CPAP in these patients. We have, as an institution, we are not using it due to the risk of aerosolization and risk to providers. The third important aspect, or the third and final important aspect of ARDS management is conservative fluid therapy. So this is the FACT trial, which came out in NEJM in 2006, I think. It divided or randomized patients into two strategies: conservative and liberal fluid management. The conservative fluid management, they started diuresing patients as soon as there was as soon as they had shock reversal. So once their shock was under control and there was no end organ injury, they started diuresing these patients and also limited fluid boluses and such. They did not find a mortality benefit, but they found that the patients with conservative fluid management had much shorter duration of mechanical ventilation. And they also did not, the other worry was, would that increase the risk of non-pulmonary organ failure, such as AKI or other organ failure, which they did not find a difference. So dry lungs is better for ARDS, and that is something we would practice on our patients. The only thing to keep in mind is we are to give them the first few days to, if they are in, to kind of equilibrate when they come. We don't hit them with diuretics on day one. We see how their shock is. We probably wouldn't start them on maintenance IV fluids, but we would be cautiously watching their organ function and how they're doing the first few days, and then we would consider diuresis or getting to an even fluid balance as early as possible. Based on these factors. I sort of touched on this. So one aspect I want to touch on is CVP. We all have moved away from using CVP generally, but then we have using a lot of CVP-based volume status assessment for these patients. And part of the reason is we are limited by what we can do due to aerosol protection, droplet protection, and PPE donning, and it is tough to go and examine these patients whenever you want them to, unless there's a real clinical need. So what we have done is, most of these patients have central lines. We are charting CVP in Epic and transducing it so that we can, at least the extremes of the numbers and the trends gives us an idea of volume status. The way I would look at it is, if somebody has a CVP of 1 or 0, I'm probably not going to diurese that patient. If somebody has a CVP of 15 or 16, then that might be a data point which will allow me to decide on whether this patient needs diuresis or not. co-infections, we have low threshold to start antibacterial agents. So the MGH practice has been, we'll send cultures after they're intubated, and we start them on their community-acquired pneumonia protocol, which is ceftriaxone and azithromycin, and then we'll escalate or de-escalate based on cultures. ECMO. So if despite proning, despite paralysis, despite best PEEP, their PF ratio is still less than 150, that's when we would call the ECMO team. We call them ahead of time than later, because we don't want them, we want to do it in a controlled way rather than in an emergent way. So having them on board ahead of time would be highly beneficial. Another topic is extubation, which we have extubated a few patients of COVID, but then we'll be approaching that more and more as we move further into the next month. So we have we perform a very long and rigorous SBD. What typically, as most people do, is about 0 or 0 for a couple of hours. And we have a very high threshold for extubation. We want very low risk for reintubation of these patients, because reintubation is not trivial from any standpoint. It provides, or it leads to more exposure to people who are reintubating, and also other providers will be in the room. So we want to be very sure while we extubate these patients. There's some amount of shock we see in these patients, but rarely do we see profound shock. The majority of it is distributive. Large portion of it, I think, is probably contributed by sedation, the high amount of sedation these patients have to be on. There's some reports of cardiogenic shock in the literature, and a lot of that is related to troponin elevations. There are some reports where they have needed VA ECMO for really a documented decrease in ejection fraction. The real percentage of it and how much of the population actually, or how much of the ICU population actually needs it, is unclear at this point based on evidence. But if we have escalating pressure requirement, that is something I would keep in mind. Aranya from our department has put together a focus team, a point of care ultrasound team, who would do a bedside echo if there is a suspicion of cardiogenic shock in these patients. The etiologies are thought to be viral myocarditis or stress-induced cardiomyopathy. In fact, at MGH, we had one patient who was on VA ECMO. Other traditional aspects are acute kidney injury. All these patients require large amount of sedation. They all develop ileus, many of them develop ileus. So we start enteral feeds much early in them. We do an aggressive ball regimen ahead of time and start standard DVD prophylaxis. We limit the number of procedures we do on these patients. We rarely or not do any bronchoscopy, because that usually doesn't add any value to a mini bowel or a endotracheal aspirate sort of looking for endotracheal aspirate to look for respiratory cultures. We are not doing daily chest X-rays unless there's a real need for it, real indication for it. No echo only when needed as a point of care. You're not doing traditional echoes, and you're also limiting CT scans unless it's really medically needed. I have one slide. We're on the last couple of slides here. This slide on focus therapies, and I put it out here because there's been a lot of talk about what therapeutic agent would work for these patients. Hydroxychloroquine has been in the press a lot, and a lot of our patients were on hydroxychloroquine, and we've been treating patients for about first 5 days at the presentation of hydroxychloroquine. The rationale is that it kind of it removes, or it affects the stability of the lysosome and the endosome in which the viral particles are in the cytosol, and thereby it destroys the virus in that way. It was based on a really small study which had a lot of problems with it, a lot of pitfalls with it, that it was recommended or people adopted it. But there are ongoing RCTs which will probably shed more light on this issue. It is probably adopted more because it is sort of a low risk drug. The main issues with it is it prolongs QTC and can cause arrhythmias, which we have seen in some of our patients. Everything else, like hydroxychloroquine plus azithromycin, has been looked at. Statins, there is poor supportive data. We are initially putting our patients on statin. We are moving away from that practice now. And we're only using it if they have other cardiac or other cardiac indications or renal indications for it. ACE inhibitors, there is a lot of controversy on that the coronavirus 2 binds to cell enders through the ACE2 receptor. How ACE inhibitors interacts with it is really unknown. There are ongoing RCTs, but whether it actually promotes infection or is beneficial to fight the infection, we actually don't know. So our policy is just to continue ACE inhibitors as you would do in a critically ill patient, if there's no AKI and the patient is not on pressors. Remdesivir, we have an ongoing RCT. I think we finished recruitment in our center. There's a compassionate use data in about, I think, 50 patients, which came out in NEJM, which showed promising results. It's actually a direct agent which directly acts on the viral RNA polymerase. So that would be something we'll be looking forward to getting data, looking forward to see the results of the RCT. The lopinavir, ritonavir is again HIV drug, which again it works against RNA viruses. There's a small RCT which did not show a benefit, but we are awaiting a larger RCT which to look at the data. Inhaled nitric oxide is Lawrence Zabara from our department is looking at nitric oxide as a therapeutic agent, and we are still it is given as part of the study. Steroids, again, poor supportive data in other SARS and MERS and H1N1. There's data showing that steroids might actually be harmful in these patients. So unless there's a strong indication for steroids, we are not using steroids. Then other is IL-6 inhibitors and convalescent plasma. Again, all of these are again part of RCTs and not recommended and available as therapy unless the patient is enrolled in an RCT, which is looking at these drugs. This is my last slide, actually. So we have the NGH treatment guide, which basically has everything what we sort of talked about. And this actually also a living document, so to speak. As new information comes, this has been modified. And this version came out, I think, day before yesterday. And it'll continue to be modified as we know more about the disease. But only one box of this I want to focus your attention on is a change of usual care. So no routine chest x-rays. So routine DVD prophylaxis. We have a very high threshold for any invasive procedures, travel out of the unit for a CT scan or any other imaging study. And we're also bundling bedside procedures. So we have which means that we have a team which does all the intubations in COVID patients, which are contributed members, actually volunteers from our OR anesthesia department, the OR anesthesia group. We have a line group which actually bundles doing all the lines in these patients after they're intubated. So there's actually a group of people, including IR folks, anesthesia folks, and surgery folks who are doing the central lines, the dialysis lines, the OG tubes, and the arterial lines in these patients, all by the same person in the room, so that we can minimize exposure. So some of these are things which has been happening and probably continue to like evolve as we see more of this. And this portion of it is basically what we talked about, the cornerstones of ARDS management. So one thing I want to just say as I end this with this last slide is that this basically what we're seeing is mostly single organ dysfunction ARDS sort of picture in these patients. And these patients are taking about like majority of the patients are being vented for more than a week. So these patients take time for their lungs to recover, and there's not a whole lot we can do for ARDS rather than giving them low tidal volume, conservative fluid therapy, and prone positioning. So so there's not a lot of delta in how these patients improve over a period of time. The sort of activity when they come into a unit, when they get lined up and they get intubated. But after that, it is just time and standard ARDS management until their lungs improve by themselves. I can take it. Take any questions. I think we are short time a little bit.
Thank you. This is Dong Dong Yao from Mesan here. I have a few questions. One is there any significance for FiO2 adjustment for this? How do you adjust? That's the one. And the second one is the conservative fluid strategy. Is any difference between the crystal versus colloids? Because usually, I don't know if the ARDS patients usually is like elderly patients, same population as the COVID, because the acute kidney injury is pretty, the rate is pretty high. And do you worry about the, I know there was previous evidence for ARDS for the fluid strategy, but for those elderly patients, their kidney function probably is already down. Is there any damage with this conservative fluid therapy? And what's your, like, how do you monitor? Like, what's your, like, how do you how do you make a plan? Like, how much fluid you give to him? What's your endpoint? Do you monitor the urine or something else? Thank you.
Yeah, perfect. Thank you. Great question. So the two questions are, one is on how to decide on the FiO2, and the second question is conservative fluid management in the setting of kidney injury and organ dysfunction. So the FiO2 question. So FiO2 is we want to. So there we use either the two strategies to do that. We can use the PEEP FiO2 table, which I showed, which is an ArtsNet table. We can set the FiO2 and PEEP just based on this table. And the other thing is, what we typically do is compliance. So we do a best PEEP trial, get the compliance, which is the highest compliance or the lowest dying pressure, and then we titrate FiO2 to get to a SAD of 90 to 96, or 90 to 95 or 96, and that is that is sort of the target saturation based on various ARDS trials, which actually a couple of which came out recently, James. So best PEEP to target compliance, and then whatever FiO2 is needed to maintain a SAD of 90 to 96. Conservative fluid therapy question. So it is the what is the right fluid balance, or what is evolemia actually is a $1 million question. You asked like 10 people, everybody is gonna probably give you a different answer, and that is something probably in the ICU we debate about every day in our rounds. It is really a challenge. The way I look at it is, these patients do not have the only. I try to, after the first couple of days, there's no. If they're not in major shock, meaning their leopard requirements are not more than 10, and most of their leopard requirements are something which can be supported by the amount of sedation they are on, I would try to keep them on an even TBD. I would also use other parameters, like exactly like you said. I would look at lactate, I would look at urine output, I would look at the CVP, and put it all together. And if I get a cohesive story of where their volume status is based on that, I'll try to attain that. So what I guess I'm trying to say is, I'll try to look at the TBB, which is more a goal for me. If the patient has adequate urine output, if the lactate is not high, and if their CVP is not less than 3, then I would diuresis them to keep them at a TBB of net even. Colloids versus, so again, AKI in the setting of older patients, we are seeing a lot of AKI, and I've talked about this to a lot of my colleagues. The data is actually also coming up, is also just evolving, so it's tough to know. But it seems like patients are the AKI is more related to the disease process itself, as part of the sepsis-related AKI than anything else, because many of these patients already have AKI as they're coming in. But you also raised an important point. We should not be over-aggressive with diuresis in the patients, at least in the initial few days. one reason is AKI. The other reason is having an AKI actually bumps them off like many of the trials, like antiviral trials, which are probably a lot more effective than actually conservative fluid management if that's an effective drug. So we should be careful not to do that. Crystalloid versus colloids. There's no data saying that one is better than the other. So we are majority of our resuscitation is with crystalloids. Any other questions?
There's a question in the chat. So,
yeah, look at that. I see a couple of questions here, so maybe I'll just go through them from top to bottom. So there is a question on just what PF ratio is. So PF ratio is the PaO2 by FiO2 ratio, and that is a measure of what lung injury is, or how severe the lung injury is. If the PaO2, like from the PaO2 will be measured from the arterial blood gas. If it is 100 for a patient whose FiO2 on the ventilator is 50%, so our PF ratio would be 100 by 0.5, and that would be 200. So PF ratio will be 200. It allows you to sort of decide on the severity of ARDS. If somebody has, so the Berlin criteria divides ARDS into mild ARDS when it is when the PF ratio is between 200 to 300, moderate when it's between 100 to 200, and the PF is less than 100, it is classified as like severe ARDS. In our patients with COVID, what we sort of use PF ratio to help with management and sort of deciding when to do proning, when to call ECMO, that sort of thing. How we do that is if when the patients come in after the best PEEP trial, if their PF ratio does not improve to more than 150, then that's when we probably think about seeing what the cause is. If they still have vent dysynchrony, we'll paralyze these patients, and that if that doesn't help in increasing their PF ratios to more than 150, then we prone these patients. If that also, despite proning for 16 hours, that is not improving the PF ratio, then we are calling the shock team for ECMO. That's how PF ratio helps us. The second question is MGH considering proning awake patients in order to possibly avoid the need to intubate? Great question, yes. I'm not really involved with that because it is more of a medicine territory, not so much in the ICU, but then yes, the people on the floor are being proned, and there is a protocol for that. I think they're doing it. They're doing it at least for an hour when the patient has an increasing oxygen requirement, and encouraging patients to stay prone or lie on their belly as much as they can. Of course, by monitoring them to see if how their oxygen requirements do, or if it's worsening or getting better. But that is something which is being followed.
Sorry, I have one more question. What's the protocol for sedation for this patients at ICU and MS General?
Great question. It has been a challenge for us in some of these patients. There's, as far as I think we will come up with, or there will be a more standardized way to deal with this in the near future. But what we have been doing, or my experience or my colleagues' experience, has been that we initially started off, we've been using propofol, but we quickly realized that propofol, you actually need almost really high doses up to 80 to 100 mics per kilo per minute to actually keep them sedated. And even that is usually not not enough. And that has been causing hypertriglyceridemia. So we quickly adopted and moved to using dilaudid drips, so high dose narcotic drips. Some patients are even up to like 4 to 5 milligram per hour of dilaudid drip, and that is helping. The other agents we are using is ketamine, and so there's a lot of polypharmacy here. We are using a combination of all these three drugs, to minimize vent synchrony, minimize vent dysynchrony in these patients. We're also using isoflurane more recently when we are using anesthesia machines to ventilate these patients.
Thank you. Thank you.
Sure. Anything else?
Sonny, I have a question. So with, we want to minimize our lung injury. We want to minimize the volumes that these patients are taking. When we're doing our decremental best PEEP trial, that's potentially injurious to some of these patients because we do ramp them up to a pretty high PEEP before coming down.
Right. We don't. I mean, the goal with the PEEP trial is that we're not increasing the tidal volumes. We are only increasing. We're not increasing the tidal volumes. We're only increasing the PEEP. So plateaus will be much higher. That's a point very valid and well taken. Although that we just come up to the attention of a lot of us too. There have been a lot of instances where we're doing multiple best PEEP trials or multiple like recruitment maneuvers in a day, and that has to be looked at with caution. It more so because ARDS comes in sort of it is a gradation of things, but at least in two big flavor pictures. There are patients who have recruitable lungs and patients who do not have recruitable lungs. And the ones who have recruitable, it's tough to know which one is which, but ones who have recruitable lungs, a recruitment maneuver and a high PEEP would be really beneficial in improving their mechanics and their PF ratios, but it would be detrimental in a patient who does not have recruitable lungs. So yes, and I would only do it in the context of a best PEEP trial. I would probably not do it in the context of somebody just being hypoxemic. And especially with the recent data from JAMA, which came out a couple of years ago, showing that high PEEP strategy actually could cause increased barotrauma in these patients. Although there have been a lot of criticisms to that study, but that is one study which recently came out, which shows that high PEEP can lead to barotrauma and bad outcomes. All right, I think I see some more in the chat box. No. That's any other questions, guys?
Thanks so much, Abraham.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you so much, Abraham.
You're welcome. Thank you.